Welcome, everyone. My name is Jen Sharon, NHIA's Chief Operating Officer, and I want to welcome you to our office hours, Friday, January 29th. As you can see, the NHIA team was a little busy, and we actually got the dates wrong there in the PDF, but you do have that available for download, and we have corrected on the slide on the fly. But I want to turn it over to Ryan Garst for the programming, and just a reminder to put any of your questions in the question tab at any time during the presentation, so we'll get to everybody's at the end.
Hey, good morning, everyone. Thanks for joining. We have a lot going on that's new, actually, and we'll be going over that here quickly. But the first and foremost, we're going to review the updated Bamlanivimab EUA that just came out, and we're going to talk about those changes. There was 3 major changes that are pretty significant. We have a couple of updates to the data entry guide, partially as a result to the update for the Bamlanivimab EUA. Also, there is going to be a new office hours registration link that we'll need to make sure that, hey, Jen, your Teams thing is up. And then, so because this is the last in this series, so there will be a new link that you'll have to go in and re-register for and things like that. And then we're going to take a sneak peek at some clinical outcomes review that we're going to be presenting to HHS and CMS actually in the next hour at 11 a.m. Eastern. So wanted to give you a sneak peek of that on all the amazing work you're doing. Then we're going to have Justin Witzel from Delta Medical give a little brief sort of his experience in the pilot. And then we're going to have Bill jump on and do some reimbursement reminders and go from there. So Jen, next slide. So hot off the press, this was late last evening that there were updates to the Bamlanivimab EUA. The 3 areas of change were in reference to dose preparation and administration, hypersensitivity reactions, and also a new warning that they've added, which was clinical worsening after Bamlanivimab administration. So we're going to talk dosing and preparation and administration next slide, but this one, for the hypersensitivity and infusion-related reactions, they've added symptoms that are cardiac in nature, so AFib, tachycardia, bradycardia, and arrhythmia. So those were additions to the symptoms that they've listed for anaphylaxis and IRRs or infusion-related reactions. So just to make note that they are noticing that, and they added that update to the EUA. The other section is a new section where there were reports of clinical worsening seen after administration of Bamlanivimab, fever, hypoxia, cardiovascular events, and altered mental status. However, there is a caveat that they mentioned that that's not known if it's related to the COVID or Bamlanivimab. As we know, those can be symptoms potentially of COVID-19, but again, they seem to appear more frequently in some patients after administration, so that's just something to keep an eye out for as well. Next slide, Jen. Here is really the huge change that we're seeing, and it's in relation to the total infusion and the volume and the infusion time. So this is pulled directly from the EUA. As we know, prior to this, the only option was 250 mLs over 60 minutes. However, they have changed both the volume and the infusion time. So you can see in the slide here that they're now saying that you can have a bag as small as 50 mLs in which you add the 20 mLs of Bamlanivimab and infuse that over 16 minutes. You can do 100 mLs at 27 minutes and 150 mLs at 38 minutes. So this is a pretty significant change, obviously based on where we were at before, with only having the 250 ml over 60-minute option. So therefore, we now have 4 different infusion time options that you can administer to these patients. However, of note in the red here, it still requires the filter. It still requires that post-infusion line flush, which we're recommending a 50 ml normal saline bag to make sure that that tubing gets every ounce of the drug into the patient. There's still the 1 hour post-infusion monitoring period, and the refrigeration and storage for room temp and refrigeration after compounding or mixing. It's still 24 hours refrigerated and 7 hours at room temperature. So this is a pretty significant change that I wanted to make everyone aware of. They've been testing these different infusion rates and volumes, and they've made an update to this. So this is pretty big. So just making sure everyone is aware of that. Next slide. So a couple of different data entry updates that are out there now. This is regarding the clinical data. And thank you again to those of you that are reporting this clinical data. It is extremely important, as you're going to see in the next couple of slides. And it is optional, but those of you that have, it's been fantastic. We did add date of infusion as a column. That was something that was missing, but now we've added the infusion time, and there's a drop down for 16, 27, 38, and 60. For those of you that would be doing this with the shortened infusion time, we're looking to see if there's a trend with a shorter or decreased infusion time and how that may relate to potentially increase in ADEs. And we're trying to take a look at that from a clinical perspective. Jen, next slide. So here is the link for the new office hours. We've scheduled them out through March. I'll also email this link when I send out your data entry guide to fill in for this week. And we've also updated it on our BAM pilot website, so you can go there as well. Just re-register, and then once you do, it'll take you again through all of the series through March for every Friday morning. So we just wanted to point that out. Go on. Next slide, Jen. So we have an opportunity from NHIA to present to some folks at CMS and HHS a little bit later today. And this is all, we wanted to put in some slides here. I won't take too long, but if you can see, we have 36 organizations enrolled with 172 locations. We've allocated over 3,300 doses, and we're coverage in 46 states. The majority of our providers are single site locations, and then multi-site, and then we have a couple of hospital affiliated organizations. So just wanted to point that out in terms of what the look and feel of you all and your organizations is for the program. These are, the next couple of slides are slides that we will be presenting. So next slide, Jen. So here's some statistics. As of 124, we've done 252 doses, which is about 7.5% of the doses that we've allocated. There's been 37 locations, or roughly 21.5% of the locations in pharmacy locations in the program have infused. So that's actually sort of in line with the current usage nationally for all. The usage of MABs across the country is about 25 to 30%. So we're not far off from the national average. But again, we know one of the missions of our program is to get more doses to these populations, and we're working on a variety of different things as well to help expand that usage. So the average provider has done 12 doses over the course of the pilot program. 60% of those doses have been in skilled nursing facilities, and 35% have been in assisted living. And there are a few providers that have gotten special allocations and permissions to use outside of the pilot, and that's about 5% of our doses. But the majority is in skilled nursing facility. And another really great statistic is the reason that we need that infusion date in our data is that from first symptoms to date of infusion is less than 4 days. So it's 3.83 days. That is fantastic. So they've had their first symptoms, they've tested positive, we've gotten the referral, and you've gotten the infusion to the patient in less than 4 days from the first onset of symptoms, which is really fantastic. And we have that on 58 of the patients. So again, not a huge number, but at least in those 58. One thing I wanted to point out is there was some instance where there was a 14-day period between date of onset of symptoms and infusion, and that is outside the EUA because it has to be within 10 days. So just remember that it is within 10 days of symptom onset that you do have to administer the dose. Next slide, Jen. And the geographic characteristics, which is one of the purposes of our HHS pilot, is to get into underserved populations or or more rural, because that's one of the goals. And as you can see, roughly about 62% of the doses have been infused in cities with less than 100,000 residents. So that's really a great number in terms of getting into a population that is a little bit more rural, doesn't have as much ability to receive these types of infusions. So that is a really excellent representation of getting this to a population that is high risk in not overly populated areas, which can sometimes be a challenge in the more rural setting. So that's really good information and really interesting from the perspective of where you guys have infused. So that's really really telling and really part of our program. So that's great. Next slide, Jen. And then just some brief patient demographics. The mean age is 81.8 years old, and roughly 69% of patients are female. One thing to point out here in the number of patients that we have gender and ethnicity, we only have 89 patients of the total 190 that we've received data on reporting that ethnicity. But it is, if you can, if those that are reporting it, again, it's the clinical data, it's optional, but you can see there's been a little bit of disparity between white and African American. So, it is interesting, and we've heard some of the disparities in care with COVID. So this would be interesting if you can to for those that are participating, to ensure that if you could fill out that ethnicity column, that would be really helpful to get a better picture of who is getting infused. So that would be great. Next slide, Jen. And I think this may be the last slide in terms of what we wanted to present, but you can see that, 9 of 189 patients, 93% of the patients reported no infusion-related side effects. There's no serious adverse events, drug events, no reports of hospitalizations. And yes, we did have 2 deaths, but those were unrelated to the infusion. You can see that both of those patients were 86 years old, 1 female, 1 male, and had multiple comorbidities. Next slide, Jen. All right. So those last few slides with some of that data, just wanted to give you some insight as to how successful the pilot has been thus far, and thank you for all of your efforts. And now we're going to turn it over to Justin Witzel. He's a PharmD and Pharmacy Director at Delta Medical Infusion in Fayetteville, Arkansas, and he's just going to give a little bit of a insight as to what his experience has been, and then we'll move on to Bill, and then we'll open it up for questions.
All right, good morning. Thanks for having me in NHIA. I appreciate the effort to kind of speak out about my experience with this and what I've had to kind of go through to get this thing started. I think that I've had a history with this that a lot of people have, a lot of pharmacies, and be able to get this allocation sent out and not actually being able to provide it as quickly as I'd hoped. I think I had a week and a half, maybe 2 weeks between the time that I received my allocation and the time we actually did our first infusion. And we had reached out to several facilities, especially in our main service area, to be able to provide these medications to, thinking, man, this is going to be a great thing. People are going to reach out to us. They're going to want it. And it was really a slow response to that. I even involved some of my other smart medical supply sites that have marketers in those areas that said, go out there and try to talk to these places and let them know that this is available, and I want to provide this to them to prevent these patients from going in hospital and kind of free up some of that space. So we hit it pretty hard, and I talked to a lot of people, and it really came across, I think, for me, I was trying to sell them something when I called these facilities, and it was very frustrating at first. But then we did basically get invited, and I found out that was actually the first one that was completed in state, and that the state of Arkansas had actually provided some different information to these facilities that didn't quite match up with what I expected, and had some wording in there their documents that said that they should probably have a doctor or an APN or a PA on hand to be able to do those. And so as I spoke to those facilities, the first thing that they came out and said is, no, you're not going to do it. We're going to do it because the state says we have to do this. And so, okay, well, it's not what I was expecting, but obviously I'm going to go ahead and provide it to you. So we ended up providing that to them. The first dose that we gave was about 5 hours from us, but I think they had like 8 patients that they wanted to have done. So we sent all those out that day, and then they saw that the results, how easy it was and the lack of adverse effects that followed that, and they piled more onto us. And then we got some more of the facilities that were kind of within the same company. Some of the other areas where we saw people infusing are some of the doctors that work in hospitals who actually provided that infusion in hospital and then came out to these facilities or the medical directors of these nursing homes, long-term care facilities, and said, okay, yeah, we've done it in the hospital. We're okay to go ahead and proceed with this. And so that's how we kind of have spread out, as some people becoming more familiar with it. It's still a lot of a process to go through to try to get all that put out. But as of today, we've done 30 doses we've sent out so far, and hopefully get some more sent out at this point. But there's still a lot of hesitation from the sites, and I think that's the one thing that really hurts us, is having that hesitation and trying to talk these providers into go ahead and doing that in facility. And so one thing that I've been trying to do is provide information that comes out not just from these office hours, but from the HHS, the ECHO web series, information that's provided as far as outcomes go and how many people are actually have adverse effects from this. And one I watched a few weeks ago were doctors in hospitals saying, we have not seen any problems. And I was speaking to a hospital in state, and the doctor over there about it, and she had said that we actually had one adverse effect in the hospital, but it was somebody that had infusion reactions to everything, and they just failed to mention at that point. But it's been fairly safe, and I think a lot of people are seeing that, and they're more willing to go ahead and proceed with giving those. So the only thing we do is just we're going to stay on top of this, and we're going to go ahead and keep hitting these facilities and make them aware that they're here, and talking to hospitals and saying, hey, make sure you know that this is available in the facility. So if you have somebody or a facility want to do that, let us know, and we'll talk to them about this, and we'll see if we can provide this in the pharmacy at that point, or not in the pharmacy, but in the facility, and have us do it. That way you don't have to have somebody worried about being there. We can send our own nurses out. We can monitor. We can do all the things that are necessary, and you don't have to worry as much about it. I think there's a lot of hesitancy with these facilities and just fear that it's not going to go right. I mean, you're doing a drug that hasn't been out that long, and you really don't know what the outcomes would be, but history has shown so far that the outcomes are good, and the reactions to these are minimal. So I think that as we continue to push that, it's going to be easier for us to be able to provide more of these infusions outside of the hospital, and free up that space that needs to be done. So it's a slow start, but we were able to kind of push on with that and be able to provide a few more doses. And I think it's going to become more popular as we're able to push more of these out and see the benefit from it.
That's great, Justin. Hey, I do have one question. You talked a little bit about the fear of this being administered in nursing homes, and we can certainly understand that. I think, even any MABs, how often is that, administered in a nursing home? Is there specific data, or did you develop tools, education to be able to kind of move them past that fear?
Well, yeah, going back to the meetings and watching some of these web series and providing or to collecting that data or that information, saying here's what they have seen. It's not just us. I can tell you what we've done, what we've seen, but it's not. We don't. Just because we see this doesn't mean it's odd and you're going to have a different outcome. I can show you information from hospitals. I can show you information from other places that say, hey, we've had good experience with this, or I can, talk to NHIA about it and say, yes, we're, as the data we collect with this shows that these adverse effects are just rare. I mean, they're less than 1%, I think is what was said with most of these. And so I'm relying on other information that I gather every week from these to be able to provide that on. And as I do say this, I've noticed that there has been a difference with this, and people liking, hearing that there's not an issue with that, or tell them, I've given over 25 doses at this point, and we've had 0 reactions to it. And then people appreciate that more. I think they're less hesitant to do it once they know that reaction may not actually occur at that point.
That's great information. I think, Ryan and I have heard very similar reactions from areas about administering the medication. So we thank you for everything that you and your team are doing for the pilot. We're going to keep Justin on, so please feel free to put your questions in, and he can answer them at the end. And I think at this point now, we're going to move on to Bill.
All right, thanks, Jen. Just a few reimbursement updates. Last week I talked about place of service. In our original guidance from CMS was that you should use the actual place of service where the administration took place. I then heard from a provider that submitted claims and received a denial based on place of service. So using the actual place of service is okay if you're not enrolled as a mass immunizer. If you're enrolled as a mass immunizer, you should use place of service 60, which is actually mass immunizer center. We understand that you're not a mass immunizer center normally, but the way this benefit is set up, if you're enrolled as a mass immunizer, there are edits in place at the AB Max that will kick it out for anything other than place of service 60. So we talked with the MAC in question and also with CMS to confirm, and you can see the reference there to the Medicare Internet Only Manual, chapter and verse, where this information comes from. So if you're enrolled as a pharmacy with the AB Mac program, you should utilize the place of service where it was actually rendered. Skilled Nursing Facility 31, Nursing Facility 32, Assisted Living 13. And this particular scenario, like I said, was brought to my attention by a member that was getting a denial. If you have denials that you'd like to talk about, please email me. We're happy to research. We've got a line of communication with CMS, and they have been very good in getting us in touch with and having research done by the MAC where the claims are being denied. So they've been responding very quickly, and we were happy to work through this one. My email address is at the bottom of this slide. That's really the update I wanted to give. The next two slides, next slide, Jen. First is really the rules of the road here when it comes to submitting claims, enrollment, and submitting claims for the COVID treatments, and monoclonal antibodies fall under the same billing rules as the vaccines, the COVID-19 vaccines, hence the ability to enroll as a mass immunizer. Next slide is a series of links to where you can get information regarding coding, allowable amounts, the facts around no patient copay, that you're to bill the AB Max for both Medicare fee-for-service and Medicare Advantage, and so on. And that is the end of my updates here, Jen. So we can go to the Q&A. We've got a few minutes left.
Great, thank you. So I will encourage you all to just put your questions in at this point. Right now we only have one question in the queue, so we want to be able to give everybody enough time to get those questions in. Ryan, would you like to take the first question on some combination therapy?
Yeah, so there was a question that came in about the use of a new product that's a combination with Bamlanivimab. It's Atezolizumab. I can't say that one. That one's a little bit tougher for me to get off the tongue, but
that's why I let you answer the question. I didn't want to mispronounce it.
Right. So about the fact that there was some recent study and research that came out regarding the combination, and that Lilly may stop manufacturing BAM to focus on the combination. One, the combination is not yet approved. It doesn't have an EUA or anything like that. And there was a study that was posted, I think it was back on like January 22nd, maybe, or 23rd, maybe even a day or two before that. But it was in JAMA Network, and it was a study of 577 patients that received 3 doses of the monotherapy of BAM compared to placebo, and then treatment of the combination, and both versus the combination versus placebo. So obviously both reduced viral load. There was a little bit of a larger reduction in viral load at day 11 with the combination product. So, you know, we'll see what that comes out of that or whatnot, but I do know that there is a supply of Bamlanivimab available. I haven't heard that that's an issue. And, you know, without them having any type of FDA approval or authorization, I think time will tell. But that study, you know, did show some promising results. So we'll see. I think that's the best I can answer that. So I think it's just time to tell to see what happens.
Great, thank you. All right, and someone had missed the name of that combination drug. Would you mind repeating it? And it is a question, Ryan. I'm not making you just repeat something that's difficult to
really,
pronounce.
Jen, Friday morning. Bamlanivimab, and I'm going to call it Etesevimab. It's Etesevimab. It is the combination product that they are looking at, and they've done they're in phase 2 and 3 trials with it. So we'll see. But yeah, that would be the name of it. I'm not going to say it again.
It is a Friday morning here at NHIA.
I'm really good at Bamlanivimab. Etesevimab. Etesevimab. We're going to go with that, even though it's not the correct saying. But that one takes a little bit to roll off the tongue. But yeah.
You need an extra cup of coffee for that one.
Yes.
All right. So we'll post the revised EUA link on the BAM pilot site.
Yep. I was just going to say, Jen, that's already done. So
okay.
We already have that done. So the new, and it's the EUA fact sheet for healthcare providers. The actual EUA is a letter to Lily, but it's the EUA fact sheet for providers. And if you go again to our BAM website and go and roll down to the resources, you'll see that it'll say Bamlanivimab fact sheet for healthcare providers. So if you click on that, that will be the new and updated fact sheet for you with all that, with everything in there, but specifically that table with the new volumes and infusion times.
Fantastic. So that was our last question for today. Again, we thank all our participants in the pilot. The data that you're submitting, the things that you're doing out in the community is of the utmost importance, and you are saving patients' lives. And that's what it's all about. So thank you. You guys have a great day. And just a quick reminder, there is a new link for the office hours. So go ahead, sign on to the BAM pilot site. The link will be there. And I think, Ryan, you're going to email everybody the link too so that they can get themselves signed up.
Yep, sure will.
All right. Everybody have a great day. Thank you so much.